Hi, everyone. Thank you so much for joining us for another edition of Adam Interviews, where we are talking to folks in our community who are doing things of note. And my guest today is certainly doing things of note in our community. She is helping to heal our community every single day. And with that, I want to introduce to you Dr. Charlene Connors. Dr. Connors, thank you so much for joining us.
Thank you.
So Dr. Connors is a primary care physician in our area, and she treats numerous patients a day. And we got to talking, I think last year, kind of about the state of primary care. And spoiler alert here, it's not great. And we're going to go over the various things that are perhaps wrong with it, but also the solutions, because we want this to get better. So Dr. Connors, thank you for in advance your insight into what's happening. So I'm going to open the floor to you. What are you seeing day to day in your profession right now?
I speak only for myself, but I certainly take care of a lot of physicians, and I interface with a lot of them. And I think the challenge for me is to actually provide timely access to patients, make sure that we see everybody that needs to be seen within reason, try to navigate a lot of these prior authorization pathways, which are, for me, operationally very challenging as a private practitioner because I have a limited number of staff. We don't have a huge infrastructure that we're dealing with. There is poor reimbursement. That is not new, and I think everyone in the community is feeling that. I think there's an attrition out of medicine. I think that it's hard to recruit. And for me, as people age, they get more complicated. As I learn more and remain curious about medicine, I make them more complicated. So I want to offer more to my patients. And the time that it takes to do that, I struggle with. I have, full transparency, sucked in the last 2 years in my time management because I have a vision of what I want to give to everybody, and it can't happen within the time frame that I'm allotted, in an effort to try to manage the complexity of care, the relationship with the patient, and the economics of needing to keep a private practice open.
Maybe it was you who introduced this term to me last year, because I've been using it ever since, moral injury, which is you try to do your job, but because you aren't doing it to the level that you think it needs to be done, there's injury to your morals, your principles. Do you find that to be the case right now?
I actually live with conflict every day. A little story: when I was growing up, and I made my first communion, my dad was notoriously late to everything. And I remember running across the parking lot with my family, knowing we were going to be the last people in this massively crowded church to make my first communion. And from that point on, I, became this punctual, goddess, basically, until now, okay? Because I can't get out of my own way. When people express need in the practice, I feel like all of their needs have to be met at that one visit, because trying to get in is also complicated. So I have conflict every day. I think the moral conflict is that you have to basically orchestrate the visit, navigate the visit, and direct the patient to things that you can accomplish within a certain amount of time, but understand at the same time that you may not be able to reach their soul at that visit. You may not be able to ask about their children. You may not be able to honor their dead spouse. It's a real moral and ethical dilemma, and I know that my colleagues are experiencing the same.
I'm going to hit you with another big question here, which is, how did we get here?
So I think that, and this is, and there are books, and there are manuscripts, and there's lots of data out there about how we got here. I think that the system has probably been broken for a bit. I think it's a depleted system that we didn't replete after COVID because we didn't really have the infrastructure to do that. I think that the challenges that we see in the European Union and in the United States kind of continue. We just keep making supply chains more challenging. We make operational um, pathways more complicated, and we're burning out, staff um, to the point where they need to take breaks from medicine at all because it's kind of a crazy schedule.
So before we get to solutions and all of that, Dr. Connors, I wanted to talk about the repercussions of this. And you kind of talked about the burning out and whatnot. One consequence of the burnout is we're having more, from my understanding, more physicians go into what's called concierge medicine, where they go independent. They're not linked to a hospital like
Mhm,
URMC or RRH, and
mhm,
folks will pay a flat fee. So, for example, I spoke with one gentleman yesterday, I believe, and it was $200 a month. And he has 100 patients, and he says I can spend so much more time with them. At the
mhm.
same time, it was interesting. He said all I have is a stethoscope because he can't do a lot of the things that you or a lot of other primary care doctors can do. I guess before we get into the upsides and downsides of that, are you seeing more people go into this concierge medicine?
I think that, in Rochester, we're seeing it a little bit more frequently. Um, I don't think that there's this massive initiative yet in Rochester, but there certainly is some. If you talk to people across the country, they've been doing concierge medicine on the East Coast, in Florida, in California, the Midwest, to try to regain a schedule, regain their relationship with patients, regain some foundational capacity to interface with patients at a pace that they remember and reflect on that was positive. Um, and so I see it. I read about it. It's out there. It's a choice and it's a decision to kind of leave some of the craziness of what medicine has sometimes become.
All right, so you kind of touched upon one of the upsides, at least for the physician, which is a bit more time to spend with patients. And why don't we stick with the positive for the moment? What's a positive for the patient outside of just getting more time with the doctor?
So I'm not a concierge physician. I would say that um, certainly, based on some of the business models that I've seen, um, they have a longer time for physicals. They do have more interaction time with physicians. They have the capacity to access that physician after hours via cell phone. They have the physician would potentially do house calls. It's all very individualized unless a company comes in and assists them with their business structure. But I don't completely understand everybody's business structure. I'm just throwing it out there about things that I've seen from the patient end.
I think that's fair, and I think from the little that I have looked so far, it seems very individualized, based
Yeah.
office to office. One of the downsides that I've been reading is they are not linked to a hospital. So if there's labs or things like that, they have to try to find an independent lab for, let's say, blood work, and that's hard to come by in the Rochester area. I don't even know if there is one, to be honest with you. So, some of the potential drawbacks that you may not consider when you go into a concierge as a patient. What have you seen from your end, just from surveying the landscape?
You mean about the disadvantages of going in?
Yeah, just a disadvantage
Hmm.
to concierge at this point, given how the structure is built, where you only in our area have two hospitals, two healthcare systems.
I don't really think I can speak to that only because Um, I I don't understand, like, I don't interview patients that are in that model. Um, I do know that patients can maintain their own insurance, and so they can still participate in imaging and lab serology, even though they participate in a concierge model, so they may have dual pathways about where their resources are coming from.
Yeah, that makes sense. I guess let me ask you this then, and then we can move on. Is what's preventing you from going into concierge?
That's an interesting question. I think that for me, I know that a sizable part of my patient population um, that I've carried with me for 30 years or more could probably not manage that model. I think that, not to say that my colleagues that went concierge don't feel this as well, because I have to say that all of our decisions are made in a very heartfelt way. But I feel that then I would leave a percentage of my patients in the community without a physician. And we always have, I mean, Rochester right now is a very underserved area. So I would feel uncomfortable about that.
Yeah, and I think this may be linked to that from what my research is that it's very hard for concierge physicians, primary care doctors to take on Medicaid and Medicare patients, which is a big part of our population. So,
We're all getting
uh,
older, right?
yeah, yeah, exactly. So why don't we talk about pay? So, people might say, oh, boo-hoo, they're doctors. But from my understanding, the pay for primary care physicians is much different than we hear about for surgeons. I may be wrong there, but I don't know if you want to touch upon that.
I think probably they both have their challenges right now. I
Yeah,
think
that's
that
true.
the risk and the time that surgeons devote to patient care is extraordinary. Their life is different. And I cannot speak to that. I can only know what my colleagues go through. It is, I'm sure that they are underpaid, and live on the edge all the time. I think that, speaking from my personal experience, I think that the time I'm on the phone with patients, the time I'm in their houses, um, the time that we let a lot of wound care go out of the office for free, even though I can kind of apply for some of that reimbursement, I think that the amount of energy and time and expertise and product that leaves, we are not even substantiated for most of
Yeah.
the time. We sort of like work to work.
And on that note, do primary care physicians feel pressured based on a relationship with an insurance company to bill in a certain way?
What does that mean?
I guess, do insurance companies govern how billing is? Do they say, well, you really should do X, Y, and Z and bill this way? Or is there more flexibility on the part of primary care physicians when it comes to treating and billing?
There's not much flexibility. I mean, we're fairly regulated. I don't want to turn that into a billing infrastructure conversation because that can actually be very different between employed physicians and private physicians. Um, I just know that that we don't set our fee schedule. It is established for us, and and we can negotiate, but um, there really isn't a lot of room for that either. So we have to try to make sure that what we do in the office is aligned with our fee schedule or what the fee schedule is, and we always have to make sure that that we can substantiate our time with the patient.
And I guess I should have maybe started out with this just so there's some clear understanding. What is the difference between an employed physician and a private physician?
So private physician, basically, we have our own infrastructure. We have our own. We contract out with billing departments. We have uh, more of I guess, more of an autonomy on site in that we can sort of dictate the policies and principles that exist in the office, which is one thing that attracted me to primary care in a private situation. But I have a lot of colleagues, and I take care of a lot of physicians that are employed, and they have an infrastructure that's the university, which I have to say probably makes a lot of that stuff very more manageable. To kind of see the operational piece day by day on our end is, something that I constantly rethink. But I think we're very aligned in terms of our frustration with just the way medicine is going in general. I'm not an employed physician, and I don't know what their frustrations are in connection to institutions, but I think we're all generally aligned with the fact that the way we thought we would be doing medicine as we age is very different than the way that we are executing medicine now.
So now we get to the other big question. How do we fix this?
Well, if I had the answer,
Yeah.
I
Well,
would
all
have.
right. So I'll do this. I've given I think that you're my sixth person this year that I've given a magic wand to.
Hmm.
And I've given you a magic wand, and you can twirl it and reshape the industry as you see fit. What would it look like?
Um, well, I think that that's the infrastructure question is a part of the question that I probably should not touch. I think from my end, what I envision for me as a primary care physician who's practicing privately is that I would love to maintain the access that people need. I would love to maintain the uniqueness of the practice relative to the opportunity for calls and house calls and some of the things that make us more mobile and portable as a unit. Um, I'd like to see us be able to get reimbursed for the things that we do. And so I think a hybrid model would suit us more than a direct patient care model versus a concierge model. Um, and I'd like to, in fact, I belong to the AMA and I'm going to Washington in a week to try to petition again the complexity of prior authorization pathways.
And what does that mean? I apologize for if you've already explained it, that prior authorization pathways.
Um, well, it's something that's existed for a long time in order to regulate care and cost. Um, there are pathways of there are infrastructure pathways with both imaging and with pharmaceuticals that basically um, everybody goes through in the system that basically uh, sort of asks of the insurance company or petitions the insurance company or offers evidence to the insurance company that certain things we would like to influence, like on behalf of our patients, either a product or imaging. And these pathways are uh, designed by companies for cost saving and economics, which I understand. But the grandiosity of some of these pathways and the amount of pathways that exist makes it very challenging for me to spout off in a room what I envision for someone without really having a true understanding of the backstory that it takes to actually accomplish some of these missions. It's no longer like I would like you to do this and this can be handled. It's got to be handled by 4 people in my office and then an Italian prayer to make sure that this all gets going.
Hmm.
So it's a lot of open loops, which makes me crazy because all I do is open them and I close very few every day. But you know, I think if we could temper that a little bit, it would make life a lot easier.
I hope I'm not speaking out of school here. One of the reasons we couldn't talk earlier in the week is because you were speaking to a group in Harvard. And so I would love, if you're at liberty to talk about how that relationship happened, what you're talking to them about.
I've talked every year for the last 30 years through a group called Pri-Med. I try to leave the area, get education for my patients, bring it back. But I force myself into situations like this where I don't like to speak publicly and I don't like to get in front of an audience, but I think it forces me to teach larger groups of people about certain topics that I have an interest in and bring back all of that information fresh and exciting to share with people.
Yeah, I mean, look, it's quite an honor, for someone from Rochester to be speaking to what is likely a very prestigious group. So I'm very happy that you're available to them, and I'm happy that you're in our community. And one of the questions that's linked to that, I'm very curious. You mentioned kind of your path to becoming a primary care doctor. How did that happen? How did you even realize you wanted to go into medicine?
Well, that's kind of funny. My grandmother, um, um,
Take your time.
you didn't tell me about this question.
Yeah, I'm
um,
sorry.
she got me started my cooking and baking talent, and she lost her leg to diabetes when I was 13, and I saw that it just clipped away at her until she died. when I was just a teenager, and I saw how devastating it was to my dad. And I, thought about how I could make a difference. And here we are, you know, coming, many, many years later, having some really impressive ways of trying to
Hmm.
either put off that diagnosis or at some point in the future, maybe genomically trying to get rid of it altogether.
Yeah, it's impressive, and I appreciate you sharing that with me. It's interesting. I spoke with a nurse who has a degree in psychology, I believe, and she does work, and it's amazing. She says how many people in healthcare had that type of experience where they had someone who was sick in their childhood, and then it motivated them to try and help other people. And I think we're all better for that. And when you go to work now and you see your patients, you talk about concierge medicine and, they'll say, well, I can spend all this time with patients and whatnot. But I'm sure that you, with the limited time that you might have, get to know your patients very well. And I wonder if you can speak to the relationships that you do form with your patients.
I feel incredibly privileged to be in the situation that I'm in. Um, I know my patients. I know what they do. I know of their interests. I know of their family. I If you get the opportunity and the privilege and the honor to sit in a room with somebody and just listen to what they have to say, you become um, enlightened about how information is going to fall on that person. So you understand what kind of childhood, what kind of trauma, what kind of past experiences influence their acceptance or their lack of acceptance of what I'm going to do or recommend. And that allows me the opportunity of trying to reframe my approach to be able to get into their head a little bit and influence an outcome in the manner in which they psychologically and emotionally can handle. But I love the fun part of, who made the soccer team, who made it on
Hmm.
match day, how can I help this out, and that part I truly enjoy.
How's telemedicine creeping in? I mean, is it helping? Obviously we got into more of it during COVID. Is this a good, um, what's the right word? A good initiative or a good element to have?
I actually did very little of it in COVID. I was in houses, so I kept my office open. I was doing house calls nonstop. I did a little telemedicine, and I appreciated that. It actually helps me get in touch with older folks that are isolated, people that are on the outskirts of the geography, um, that I may physically not be able to get to, like on, during a work day or on a weekend. So I think it's increased accessibility for sure. And when people are sick at home and they just don't want to travel, it definitely adds another, flexible, mobile element to administering care.
Yeah. And then as a patient, right? So advice to patients who are trying to navigate this system as well. What type of mindset, what type of information can they provide when they are engaging with a primary care physician? What could help you do your job better?
My adage is always help me, help you.
Yeah.
And um, I try to encourage people about, like, I try to have homework for them every time they leave so that I know at least that there's a template of what we're talking about the next time they come in. It allows me that foundation, but then I launch from that foundation into that may not be their decision of the day. If somebody comes in and says, well, I need to talk about this death in my family, or I have, I can't walk. I've been sick for 3 weeks and I feel like garbage, then we can always like reframe. But I always have sort of a mindset, a plan about what I'm going to accomplish. If it changes, that's fine. But I always encourage people, bring your garbage, bring your list.
Hmm.
Um, I've gone toe to toe with ChatGPT in my office because, I have a couple of patients that are fun like that and will come in and say, well, Chat says this. I
Right.
don't mind that. I think
Okay.
it offers a lot of opportunity for back and forth questioning, for education. I It's certainly a tool to be used, but I enjoy the questions.
Yeah, that is interesting. And then Brave New World there. Well, I mean, it was once WebMD. Now you're asking a bot. So, what would be your message, by the way, Dr. Connors, to other primary care physicians, especially those just getting into the field? They're a few years in. They may feel the same type of discouragement and frustration that you have felt. What is your message to them at this point?
So I've been in that experience. I do teach other physicians, and I I never talk anybody out of becoming a physician. I think it's the most amazing profession in the world, and I am very glad I chose what I did. I always let people know that despite the complaining, and there was complaining in every profession, it doesn't mean that we're not trying to change uh, those things for people coming after us. I've reached out to people that I've either taught or interfaced with, and we offer, like a mentorship where I always tell them, don't forget where you landed. Don't forget who's ahead of you. We're all here to assist you, to talk to you, to bounce off crazy cases with, understand that there's some senior quote unquote leadership, which I don't know what sometimes what day what that feels like most days, but that can so that they don't feel non-nurtured, they don't feel isolated, they don't feel like they're completely on their own in this journey.
Yeah, I really like that. It's very refreshing talking to you. I happen to love my primary care physician.
Mhm.
In fact, I haven't had a bad one in my 44 years.
So great.
Yeah, I've been very, very lucky. I'll give a shout out to the first one that I had up until like 18 years old, Dr. Nazarian, uh,
Yep.
Panorama Pediatrics, just incredible. And so I'm very grateful for this conversation, and it's just nice to know that you're out there despite the frustrations that you're experiencing.
I have to say we're very gifted in Rochester. We have an amazing group of primary care physicians, and I'm proud to be a part of them.
Yeah, that's great. Well, thank you so
Mm.
much for the time and the insight today.
My pleasure.
All right, that was Dr. Charlene Connors taking time out of her very busy schedule to talk with us and tell us some of the issues at hand for primary care physicians in our area and what some of the potential solutions can be. I'm sure it's just good for the community to know this as we move forward and the conversation continues about how we can enhance and improve medicine in our area. So with that, I want to thank all of you for joining us once again for this episode of Adam Interviews. Please tell your friends and family about the Rochester First app, which contains the interviews that I conduct along with all the other wonderful content that my colleagues put out there every single day. Thanks so much, everyone. Take care.
Get the Rochester First streaming app today for everything you love from News 8 on demand, plus exclusive shows you won't see anywhere else. Search ROC and download for free on Roku, Amazon Fire, and Apple TV.